I'm going to go ahead and discuss the principles of sideline splinting. The team physician needs to make a decision about whether an athlete needs on-field or sideline stabilization of an injury, i.e. if they have an injury with neurovascular compromise, if there's a spine injury that's going to need motion control, if there's a significant amount of blood loss or a laceration over a joint, if there's a potential for other associated injuries, things like long bone fractures, open fractures, major joint dislocation, or severe sprains. When the athlete experiences one of these major injuries, obviously it's going to be difficult for them to leave the field without significant assistance, and these injuries are going to be needed to be addressed on the field. Properly placed splints are going to decrease pain and prevent further damage or displacement to that extremity. Depending on your resources, there are a wide variety of splinting materials and products that a team might have available to them. So it's important for the physician to be familiar with the items at the venue. For something like spine immobilization, we use backboards and things like scoop stretchers. Common items that you might have available to you for splinting and immobilization include things like cardboard, wood, wire, vacuum, traction, and SAM splints. You can also get creative and use what's available, like cardboard boxes, blankets, etc. So we're going to use long spine boarding in patients with concern for spinal injury. You can also use this for hip or pelvic pathology to immobilize the player and then transfer them off the field and onto a stretcher. The patient's going to need to be lifted or rolled onto the stretcher by a team of trained individuals and then secured in place with these straps. And this is going to be something that requires practice and training to properly apply a backboard. This is a scoop stretcher, so this can be used in players who have suspected spine injuries without having to actually roll them or lift them onto the board. So the idea is that this is going to limit your spine motion. This device actually separates into two long pieces and then locks in around the player. This is something called a hair traction splint. So this is sometimes used by EMS to transport a patient who has a suspected femur fracture. So the device applies inline traction through the distal part of the extremity. And this is thought to decrease the potential space for hemorrhage and hematoma formation, as well as potentially help with pain. There are these things called vacuum splints. So essentially these are going to work by removing air from a soft bag of polystyrene beads. And this causes the bag to kind of conform and lock around the injured extremity, which provides pretty good immobilization. These can be used for angulated fractures or dislocations, but a pump is going to be required for their application. They come in lots of different sizes and shapes to accommodate different sized limbs. And there's even like a full-size mattress device that can be used to immobilize the spine and pelvic fractures. Overall, these are relatively expensive, so they should be retrieved from the hospital after the athlete has to use them. Board splints, so this is like padded cardboard. They're pretty inexpensive and they're effective if they are applied correctly. They're made from this, padded, rigid cardboard that's pretty easy to store and to cut to appropriate sizes. Overall, they're lightweight. They don't interfere with X-ray, which is nice, and they're applied with elastic bandages, triangular bandages, or tape. So these are going to be pretty quick and easy to use on the field should you need them. SAM splints, so this is like a ready-made piece of aluminum that's covered in foam that's pretty malleable and can be formed into different shapes. You can make them more rigid by doubling them up or creasing them down their lengths. They're lightweight, they're radiolucent, and they can be reused as you need. A sling or a sling and swath are used for shoulder or humeral injuries. The sling is going to support the weight of the arm, and the swath is going to hold the arm against the chest to minimize shoulder motion. They can be used to treat dislocations, subluxations, sprains, AC joint separations, any possible suspected proximal humerus fracture. They can be easily fashioned if you don't have a sling with a triangular bandage, or just by pinning the player's arm to their t-shirt with a safety pin. So just to get into some specific splints and specific injuries. So if we're dealing with an elbow injury, you can use a long arm posterior splint for more stable injuries at the elbow or forearm, or for any type of interarticular fracture. So with this, you're going to place a splint up from above the elbow posteriorly down the ulnar forearm to the mid-palmar crease, with the elbow in 90 degrees of flexion and the thumb pointed upward. This will allow for a little bit of pronation and supination, so you don't want to use it with complex or unstable distal forearm fractures. The double sugar tong is the splint you're going to use for complex and unstable forearm and elbow fractures, because it's going to limit flexion and extension at the elbow, and also pronation and supination. So with this, you're going to have one piece of plaster or ortho glass wrapped around the metacarpal heads on the dorsal aspect of the hand. That's going to then wrap around the elbow and then end at the volar MCP joints. Another piece of orthoglass is going to start at the anterior proximal humerus, wrap around the elbow, ending at the posterior proximal humerus. For a distal radius or ulnar fracture at the or other wrist injuries, you're going to use the forearm sugar tong, wrapping around the elbow to immobilize the elbow, forearm, and wrist. You can use a volar short arm splint for soft tissue injuries and fractures of the hand and the wrist. You're going to apply that at the mid-palmar crease, almost extending to the elbow ventrally. For any hand or finger injuries, you can use a gutter splint. So radial gutter is going to be used for any injury to the second or third digits or fractures of the metacarpals. This is going to extend from the mid-radial forearm and ends at the mid-distal phalanx of the second and third digits. You want to make sure the splint is wide enough so that it can wrap around both fingers and the wrist. An ulnar gutter is going to be used to immobilize the fourth and fifth digits and the metacarpals. And you're going to splint the fingers in a position of function. For a thumb spica, this is kind of a variant on a gutter splint that's going to be used for scaphoid, lunate, thumb, first metacarpal, or UCL injuries or gamekeeper's thumbs. You're going to want to place the splint on the radial aspect of the forearm, wrapping the thumb to the DIP joint. For lower extremity injuries, a knee immobilizer is going to be quick and most efficient to immobilize the knee joint. For femur injuries, you can use a spine board to immobilize, or a hair traction device to try to apply traction to the fracture and decrease the potential space for bleeding. You can also use a vacuum splint for immobilization in displaced fractures. For ankle or foot injuries, posterior leg splint is used for the distal leg, ankle, tarsal, or metatarsal fractures, or reduced ankle dislocations or severe sprains. You're going to want to put plaster material from the metatarsal heads to the fibular neck. You want to avoid placing any compression over the fibular head to prevent any peroneal nerve injuries. Give the patient crutches with this type of splint, make them non-weight bearing, and you also want to make sure that the ankle is at a 90-degree angle. A stirrup splint can be used with this type of splint to prevent inversion or eversion of the ankle and better immobilize the posterior leg for fractures that are near the ankle. And then there's obviously a walking boot, which is a prefabricated splint made of Velcro and hard plastic, which is super convenient and comes in a variety of sizes that fit most patients. So just some tips and tricks. So splinting plays a major role in MSK injury management, especially for fractures and dislocations. Immobilization can decrease bleeding, swelling, pain, and the risk of vascular or neurologic compromise. Compared to a cast, a splint permits swelling. You want to avoid placing the splint circumferentially to prevent compartment syndrome or neurovascular compromise. You always are going to want to check and to document your neurovascular status before and after applying the splint. The splints is going to allow swelling for a few days, and then they can be followed up for more definitive splinting or casting as needed. But never want to remove a splint without a plan for ongoing immobilization. Consider how the splint's going to be used. Is this something that you're just placing quickly to get somebody as a bridge to the emergency department or to see them in clinic the next day? Or is this something that you're going to send a patient home in if they're going to stay, that's going to stay in place for a few days, in which case you want it to be a little bit sturdier and better quality. You want to try to splint players in the position of function and make sure to properly pad any bony prominences or fracture sites to prevent complications. And it's a good idea to, try to get as creative as possible on the sideline and in the training room. You have limited resources, so use what's available to you and what works as a bridge to more definitive management.